Hello, I'm Dr. Kathleen Monahan, and it's my pleasure to introduce Dr. Jacquelyn Campbell and Dr. Michelle Patch. Jacquelyn Campbell is a professor in the Johns Hopkins University School of Nursing as an international leader in research and advocacy regarding domestic and intimate partner violence. Dr. Campbell has published more than 320 articles and 7 books on these topics. She has been the principal investigator of more than 15 major studies coming from the NIH, CDC, and Department of Justice grants in her decades of policy work collaborating with domestic violence survivors, advocates, healthcare professionals, and marginalized communities. Dr. Campbell is on the board of directors for Futures Without Violence and the director of the Danger Assessment Training and Technical Assistance Center for IVP Risk Assessment. Dr. Michelle Patch is a board-certified adult health clinical nurse specialist, an advanced forensic nurse, and is an assistant professor at the Johns Hopkins University School of Nursing. Her internationally recognized scholarship and clinical practice address patients, staff, and public health safety, specifically during times of crisis, violence, disaster, and trauma. Dr. Patch's research focuses on healthcare responses to intimate partner violence and assault-related mechanisms, including strangulation and head trauma. She is a fellow of the American Academy of Nursing, secretary for the Forensic Nursing Certification Board, and past chair of the Academy of Forensic Nursing's Research Committee, and a medical advisory board member for the Training Institute on Strangulation Prevention. The presentation today is recorded, so if you have questions, please put them in the chat and they will be forwarded to Drs. Campbell and Patch. Thank you.
Thank you, Jackie. And again, I'm Michelle Patch. I'm an assistant professor at Johns Hopkins School of Nursing with Jackie. And we are giving a practice presentation, so that'll be the focus of our talk today. So we thought that we would start off with just a brief overview of some anatomy and physiology. And we know that the brain is really this very complex organ. It controls our thoughts, our memories, our emotions, motor skills, vision, breathing, all these wonderful things that we need to live our lives every day. Excuse me, every day. And we have different lobes of the brain, and those different lobes then have different roles to play, right? And so the frontal lobe tends to be more of our planning, our organizing, our emotional and behavioral control, as you see there. We may also have, if we were to have some sort of function problem that affected, say, our occipital lobe, we may then see problems with our vision. Our temporal lobe as well has a lot to do with our memory, recognizing faces, et cetera, et cetera. And if we were to cut the brain in half right down the middle and open it up, we would see these internal structures. And those are particularly influential when we're thinking about building our memory bank, right? So damage to the hippocampus can affect our ability to form new memories. And so just to kind of orient you that different parts of the brain and different injuries to different parts of the brain are going to then result in different symptoms. And then if we zoom in even further, we have our neuron, right? And so you have your cell body, and then you have the axon that comes off of it, and it helps to transmit different signals, right? And in the event that we have an injury to this, then we can have some real difficulty in being able to communicate things that we need to different parts of our bodies. So in traumatic brain injury in particular, damage to that axon, which is that little projection that helps to transmit the message between the brain cells, the brain often can create alternative connections for this and can somewhat compensate for it. When we have an anoxic injury or lack of oxygen, as we'll talk about a little bit later, the nerve cell, that cell body itself is what's damaged. And that is really irreparable. And so depending on what part is being damaged can also have different responses. And why is all this important? It's because our brain needs oxygen in order to use glucose, which is the major energy source of it. And if that oxygen supply is interrupted, we may see a loss of consciousness, generally within 10 to 15 seconds, and then damage to the brain occurs within minutes. This is just a schematic showing you the vasculature in the neck, right? And so we have the carotid arteries, which are in red, and those are taking the blood up to the brain, and the jugular veins, which are bringing the blood back down to the heart. And you can see how close to the surface some of those are. And very little pressure can actually occlude those. And that would therefore limit the amount of oxygen getting to the brain and its ability to do its work. This is also a picture of carotid, a CTA, or computed tomography angiography, looking at the head and neck, and it's showing you the blood flow, how it comes up from the neck into all of the different areas of the brain. Now we're going to talk a little bit about traumatic brain injury. And Jackie, I think you're going to take this, so I'll hand to you.
Yes. TBI is oftentimes how it is abbreviated. So you'll just hear people say TBI. And it can be caused by external force that disrupts the brain function. And what we see when we have a TBI, the disruption in brain function, we'll see any loss of consciousness. And this is evidenced by at least one of the following: a loss of memory immediately before or after the incident, an altered mental state at the time of the incident, or focal neurological deficits. So these are some of the types of TBI: a scalp injury, skull fractures, a brain injury from concussion, contusion, intraparenchymal hemorrhage, hematomas, and they can be epidural, subdural, or traumatic subarachnoid hemorrhage, or, as Michelle was explaining, injury to the axons. We can also get blood vessel injury. And we can see that diffuse axonal injury that Michelle was describing before, the healthy axons versus damaged axons. But we also see what we call a contra-coup injury. And that's when the head is violently shaken back and forth. And to apply that to intimate partner violence, this might be when someone is either hit forcefully, and that includes being punched in the face, or when they are shaken violently, and the head is shaken back and forth. We oftentimes think of shaken baby syndrome. We know it's not good for babies, but it's not good for adult brains either. And so this is another schematic of the different kinds of injury: a direct impact injury, which can be anywhere on the head or face. And then this acceleration deceleration injury, when you get shaken violently or you get punched hard enough in the face that you get the head going back and forth. Blast injuries we don't usually see in abused women. This is another common cause of TBI, especially for our active duty military. And these show the types of brain hemorrhage, the different parts of the brain where we can have hemorrhage. That's the notion of hematomas is when we have hemorrhage just beneath the skull. So there are different places and different types of brain hemorrhage. Again, here's some of the mechanisms of traumatic brain injury.
And so with this as well, you'll see that not only do you have the primary injury, but it can then lead to additional secondary injury that I know Jackie is going to talk about next.
And here is a different kind of schematic that shows one of the issues with a TBI is that the blood-brain barrier can break down, and we can have a diffusion of fluids between the brain and the blood vessels. And one of the things that happens here is if we have more inflammation, we have more down the road delayed responses like cognitive and emotional disabilities. So another thing to think about here, it's not only the inflammation from an injury. When you get injured, your body has an inflammatory response. But for abused women, we also have ongoing inflammatory responses that are related to the ongoing stress of being abused, which also interacts to make for even more cognitive and emotional long-term disabilities. And this is how traumatic brain injuries are classified. So the main thing to notice here is mild, moderate, and severe. And you'll oftentimes hear those terms. So loss of consciousness with mild TBI is less than 30 minutes. And it may be an alteration in consciousness rather than total loss of consciousness. Post-traumatic amnesia in a mild TBI is less than 24 hours, and that's when you can't remember exactly what happened. Any abnormalities on imaging, you don't see them with a mild TBI, and that's oftentimes one of the issues because any imaging, any scans come back negative. And on the Glasgow coma scale, which is where we measure how much loss of consciousness there is, it's the 15 is the best. You may even come out with a Glasgow coma scale of 15 or 14. And so that many neurological assessments may dismiss that as not being terribly important. And then you can see the moderate and severe traumatic brain injuries. The American Congress of Rehabilitation Medicine Diagnostic Criteria came out just in 2023. And they also made a more complex diagnostic assessment for mild TBI, which talks about the signs and symptoms in a very granular way. And this is, more complex, but also more comprehensive than the old way of diagnosing mild traumatic brain injury. And concussion is another term that gets into all of this that many people have heard of. And that's a traumatic brain injury, so TBI, caused by a direct blow to the head, neck, or body, resulting in force being transmitted to the brain. The force initiates a neurotransmitter and metabolic cascade, blood flow change, and inflammation, as we mentioned before, affecting the brain. Signs and symptoms may present immediately or be delayed and evolve over minutes or even hours. They usually resolve, or most commonly within days, but can also be very prolonged. And this concussion is oftentimes, people will use that synonymously with mild TBI. And women have been found to often be affected differently than men with concussions. And there seems and all of this is rather tentative because the research is has just been beginning in the last 10 or so years. So women appear to be at higher risk for sports-related concussions than men. Following a head injury, a woman may experience more symptoms or more severe symptoms, such as greater cognitive deficits, and this is incredibly important for thinking about this in relationship to intimate partner violence, poorer reaction times, more headaches, more extended periods of depression, longer hospital stays if they are hospitalized with a concussion, higher percentage of prolonged concussion symptoms, and delayed return to work compared to their male counterparts. Why this is, we aren't entirely sure. The research has not conclusively decided about this. There are some indications that it may be related to women's neck muscles not being as strong as men. So if you think about, if you get hit in the head, that if your neck can't hold your head still, that there's more shaking inside and more damage. There's also complex physiological responses to our female hormones, and there seems to be some differences premenopausal versus postmenopausal, but all of this is being studied and is not totally sorted out. But it is highly relevant to intimate partner violence, since that also affects women more than men.
And so we've talked a lot about brain injuries primarily as a result of blunt force trauma, but we also can see acquired brain injuries from lack of oxygen, which you can get through strangulation. So let's talk a little bit about strangulation. This is Sauvageau and Bogosian a few years back suggested this forensic context in categorizing asphyxia and the different ways that you can be asphyxiated. So you can have suffocation, strangulation, mechanical asphyxia, or drowning. And strangulation is generally thought of as manual strangulation, which is with the hands, and you're not lifting the body up off the ground necessarily. It could be an arm, it could be another body part. It could also be this ligature strangulation, which is usually using some sort of a strap or a wire or a rope around the neck. And often some degree of the body weight is off the ground, but not entirely. Hanging, though, is the body completely suspended off of the ground. But what we generally see when we're talking about intimate partner violence is manual most often, and then followed by ligature.
And we also sometimes see the chokeholds. And even though on that depiction, choking was under suffocation, and, the word choking technically means food stuck in your throat, but abused women will oftentimes describe what happened to them in terms of a manual strangulation as being choking. And sometimes abused women will experience smothering.
Mm-hmm. Right. And I think that's a great thing to note, Jackie, because as you've recommended for years. When we're looking at individuals, when we're talking with them and working with them clinically, it is important to ask questions that are behaviorally based, as opposed to maybe saying, have you been strangled? Because often individuals may say, no, I haven't been strangled, because they're thinking about one of these others, like perhaps they're thinking about ligature strangulation as being strangling, whereas for them, they were choked, right? But we know that choking is something that's, an internal piece of food that's cutting off your airway. So important to say things like, did you have any pressure against your neck? Did anybody put their hands around your neck or an arm push against your neck? Those type of things as we're doing our assessments. So strangulation really is this external pressure that's applied to the neck, and it can occlude, as we mentioned before in this picture here, it can block off or occlude the blood vessels and or that your airway, your air passages, and it deprives somebody of that oxygen that the brain needs to be able to use glucose. Right? It actually takes less pressure than that which is needed to crack open a can of soda. And loss of consciousness, we generally see in 5 to 10 seconds, with death following in minutes. There are different types. Again, we talked about manual, ligature hanging, postural strangulation. And often we see mild hypoxic brain injury. And even with that, we can see problems with concentration, attention spans, some coordination challenges, possibly short-term memory issues. And often it can be very, very subtle. You also might see headaches, lightheadedness, and dizziness as it goes on. And as Jackie mentioned before, these chokeholds that we also see in MMA and other forms of contact sports can also result in some of these injuries. So the mechanics of it is there's that external pressure of the neck that then causes that occlusion of the venous flow. So the blood coming out of the brain, that's the first to be impeded. And so you are still getting carotid blood up into the brain, which can cause a great deal of pressure, right? And so you might see these little petechiae inside or even in the eyes, the ears, the mucous membranes, as that pressure is increasing, no release for that pressure. That then can cause, again, with all of that pressure happening and no new oxygen being able to get up there, you can see the loss of consciousness, muscle relaxation then allows less pressure to then be able to further occlude your carotids, and that then can follow with death. Now, it is also possible you see no petechiae, because if there's enough pressure applied that it occludes both the veins and the arteries, you're not getting any blood flow in or out. There's no real pressure changes, and so you may not see that. This is a timeline from our colleagues at the Training Institute for Strangulation Prevention, and they looked at, you can see the different research studies that they referenced as they developed this. But a general idea of when we might see certain things happening, right? So if you apply the pressure at the beginning, 5 to 10 seconds later, we can see unconsciousness beginning. At around 14 seconds, you may see seizures from the lack of oxygen. Followed shortly after with a loss of bladder control and possible bowel control. Again, you may see that petechiae there depending on the amount of pressure. And then in general, based on these research studies, we have a cessation of respiration at the beginning and then at the end, where anybody in the studies that they included for that, there was no more respiration being visualized. Now, I do also want to note that for the development of this timeline, the vast majority of individuals that were in these research studies were men. And so it really does not necessarily reflect what a woman might be encountering. And so it may possibly be that it takes less time for women to start to show some of these symptoms as well. Okay, so we're going to move into just a brief primer on intimate partner violence statistics and some of the injuries. Jackie, did you want to start us off?
Of course. And intimate partner violence, IPV, is oftentimes by most of the public used interchangeably with the terminology domestic violence. So an intimate partner is someone with whom you have a close personal relationship, regular contact, identify as a couple, etc. And there's oftentimes some sort of physical or sexual contact, but it does not require sexual intimacy. The two of them may or may not live together, may be opposite sex or same sex, or anywhere along the sexual identity, gender identity continuum. So it can include both a current or a former spouse. It can be married, common law, civil union, domestic partners, or a current or former dating partner, boyfriend, girlfriend. And the violence or aggression varies in frequency, severity, and type. Usually occurs on a continuum, can include 4 different types of behavior, and oftentimes they overlap, but not always. So it can be physical violence, which is hurting or attempting to hurt a partner by hitting, kicking, or using another type of physical force, but it can also be threat of the use of physical force. So like threat with a weapon. And then there's sexual violence, again, on a continuum, and then psychological aggression that actually results in harm. In order to be considered intimate partner violence, there has to be a resulting in harm of that psychological aggression. So things like name calling and controlling behaviors. If the other person is not harmed by those actions, then it doesn't come under the intimate partner violence. Stalking is another very important aspect or type of intimate partner violence, which again can occur by itself or along with the other 3 types of behavior. And if you look at, and this is from the NSVIS survey, the CDC conducts, it's population-based national random sample survey. And the findings are that 1 in 3 women, so about a third of women, but importantly, 25% of men have experienced severe physical violence from an intimate partner in their lifetime. And when we look at the particular types, we see that the gender difference between women and men experiencing this kind of violence, in terms of being hit, there's a relatively small difference. And in fact, women report slightly more being hit with a fist or something hard than men, but not that much more. Being kicked, absolutely equal. But when we get to the more severe kinds of violence, hurt by pulling hair, importantly for us, being slammed against something, or choking or suffocating, then we see very distinct gender differences, with women experiencing significantly more of that than do men, and also the being beaten or having a gun used on you. And when we translate that into numbers of people, you know, we see, particularly for our purposes, that slammed against something, 30 million, more than 30 million women say in a year that they have experienced being slammed against something by a partner. And then the tried to hurt by choking or suffocation, more than 20 million. So these are substantial numbers that we need to be aware of in terms of long-term outcomes.
Yep. And again, this being over the span of their lifetime. So certainly the NISPIS is reaching out and asking people to participate year to year. But this is over their lifetime that there would be, again, that 30 million women affected by slammed against something, and over 20 million tried to hurt by choking or suffocating.
And they can have those long-term outcomes that we talked about before.
Yeah.
And this is by injury. And the important there, this lifetime prevalence and the knocked out after getting hit, slammed against something or choked. So that's that loss of consciousness. And with loss of consciousness, I think it's important to remember that oftentimes, if you say, did you lose consciousness? Oftentimes women will say no, because they think that's totally out, some sort of a coma. And oftentimes that loss of consciousness is gradual, or maybe just an alteration in consciousness, like seeing stars, feeling dizzy. That's important in that strangulation timeline, I think, as well as when you got hit or slammed against something, as well as being choked. And you can see the definite gender differences in terms of resulting head injury. And this is another way of trying to get at the epidemiology, and this is from the largest trauma data bank. It's a cohort analysis of 3,891 patients that were seen in an acute care setting, primarily in emergency departments. And we see that females and Black patients were overrepresented amongst those who reported intimate partner violence. And if there was a traumatic brain injury, they had higher odds of ICU admission, mortality, not being able to be discharged, and increase loss of
Like day.
length of stay. There you go. See
We have so many acronyms in here. It's hard to keep track. I agree.
the healthcare system has a ton. Length of stay compared to if there's not a TBI. So they had to stay in the hospital longer. And there's, we really need more resources during that acute hospitalization in terms of if there is IPV, helping patients decide what to do about that IPV, having social work be available, being able to connect with local domestic violence services, so that as they recover from the TBI, they're also working on what to do about this relationship for the rest of their lives. And as we've mentioned, there is more vulnerability for women and more vulnerability in terms of long-term outcomes if you're abused. And the circulating inflammatory cytokines that are related to ongoing stress of IPV, plus these repeated TBIs, that's something that it doesn't occur in other populations, like an automobile accident. Oftentimes, women particularly have been repeatedly subjected to TBIs from violence from their partner. And again, the lower level of neuropeptides in abused women with PTSD. This is the same kind of issue in terms of the circulating inflammatory cytokines. Makes it harder for the brain to repair following TBIs. That may be some of the explanation for the differences for women in healing from concussions in compared to men. Oftentimes in those studies, they're thinking about sports injuries, sports concussions versus concussions from intimate partner violence. And again, we've talked about most of this, but being hit, kicked, or slammed against something, those coup contra coup injuries, the violent shaking, and women may describe this as, well, he pushes me, shoves me every once in a while. It's not that bad. And that pushing is actually violent shaking and maybe pushing against or shoving against different hard objects, as well as repeated, perhaps, anoxic injury from strangulation. And again, that repetitive nature of IPV, it happens over and over again. Oftentimes, you know, in what we've measured, we have these women describing having their jaws fractured by being hit. And that's certainly hard enough to cause TBI, but yet, you know, they're treated for that fractured jaw and not treated for any possible TBI, let alone the cumulative effects. We know what happens to boxers. We know about the recent research, what happens to football players who often have subconcussive injuries over and over again, which doesn't sound that bad, but it's that over and over again. And they may have had head injuries in childhood, so these accumulated TBIs have that long-term issues. And we talk about difficulty concentrating, and abused women may say something like, I can't remember squat. And we also find that being strangled increases the risk of a woman being murdered by that same partner. So somewhere around 43% of women who are murdered and 45% of women who were almost murdered by a partner were previously strangled. And so this is a really important issue. We could also have a delayed death that occurs from a stroke after a strangulation.
And also very important is this idea of, you may not see any external injuries. And that does not necessarily mean there's no injury. And in fact, we have seen individuals who have died, and at autopsy, they identify internal injuries when there were no external injuries to be identified. So again, relying on being able to see fingerprints on the neck or some other type of injury as pathognomonic for strangulation is concerning. We do need to remember that often there are no external injuries and a strangulation still took place, and there may be internal injuries that we do need to find. So next, we're going to move into this signs, symptoms, and health consequences of IPV-related brain injuries. And we thought it was really important to take just a quick moment and connect the idea of biology and symptoms, because often what we hear from people are, oh my gosh, I feel like I'm losing my mind. I feel like I'm crazy. I feel like, you know, they're telling me it's all in my head. And we actually can very often take those concussion symptoms and identify a biological correlate or a cause for them, right? So someone who is experiencing headaches and sensitivity to light and sound, that can very well be a result of these changes in those concentration of ions as the brain is trying to respond to this insult. The difficulties that someone may have in thinking and processing, that is also connected to the damage that may have happened to the axons, right? Those appendages, right, that are helping to send those messages between cells, as well as the chronic atrophy and persistent impairment that we may see could be a result of cell death. And for strangulation, we have this, this is a visualization that was, again, developed by the Training Institute on Strangulation Prevention that gives you a variety of potential signs and symptoms that you may see in all of the different areas. Again, though, we stress, and they stress as well, that you may see no injury, external injuries, and there may still be, in fact, damage. And so again, strangulation has potentially devastating acute as well as long-term health consequences. In the neck, with some of the damage that we may see with shearing forces within the vessels, we can see arterial injuries, carotid dissections, where then you develop a blood clot that can dislodge and go to the brain. Again, we can see strokes. Often we see post-traumatic stress disorder concurrent in this population. Miscarriages have been reported. Multiple strangulations are also associated with increases in injuries.
And remember that dark skin,
Yeah.
that there are, it's even more challenging to see any external marks, including petechiae. That may be around the hairline, et cetera, that you just can't visualize it on dark skin. And that's where enhanced light is a very, absolutely necessary part of the exam.
You know, it's a great point, Jackie, and often forensic nursing programs, sexual assault nurse examiners, et cetera, have alternate light sources that they can use to be able to visualize changes that are underneath the layers of the skin that maybe are just not out at the surface for you to see them yet. So strangulation, the injury mechanics, and what you may see in the clinical environment, when we're talking about the blockage of the veins, right, the venous occlusion, the clinical features, they may say, you know, I had this intense like pressure behind my eyes, I was seeing stars. They may again complain of headache and having nausea. They may also have near or full loss of consciousness, and that is related to the congestion of that venous return. So the little capillaries in those small vessels are bursting or leaking, or we may actually see larger bleeds. We also can see swelling or edema of the brain as well. And the arterial occlusion can be reported as, again, I had this, I felt like I almost passed out, this pre-syncopal episode, also with headache, possibly with poor memory or memory gaps. Again, if we are keeping oxygen from the hippocampus or areas of the brain that are sensitive to a lack of oxygen and are critical for creating memories, they may not remember some of these things. And it doesn't mean that it didn't necessarily happen. It just means that they, during that injury, during that assault, they were unable to create memories about that. And then airway occlusion and psychological injury due to both the incident as well as the hypoxia, again, to that hippocampus. You again may see this reports of panic, of pain, of this feeling of not being able to breathe, being overwhelmed, fear. And again, that then goes to this hypoxic brain damage or a lack of oxygen, possible damage to their larynx or perforations to the airway. And again, post-traumatic stress disorder is unfortunately common, we see in this population, as well as depression and anxiety and other mental health issues. And unfortunately as well, historically, often we attribute the symptomatology that people are sharing with us with the psychological stress of the event, right? And the mental health consequences. And that absolutely is present. At the same time, that may have been masking to some extent the underlying brain injuries. And if we don't identify those as well and treat them in a more holistic way, then we're not able to provide the comprehensive care that we're really wanting for these individuals. Our Canadian friends have created this wonderful infographic as well that you may find helpful in your clinical practice, giving you some signs and symptoms of traumatic brain injury in the population, and categorizing them as the physical symptoms, some of the cognitive challenges that they may be experiencing. Sleep is often disturbed as well. And again, that can be from the assaultive damage, and then psychological symptoms, as well as in the red area on the left, some of the red flag symptoms that would suggest that they do need to obtain medical intervention as soon as possible. Again, PTSD and TBI, it can be very challenging to tease these apart because often the symptoms are similar between the two. But again, there is research being done out there, and we are trying to understand them individually. But again, we're humans, and this is a very complex situation, and it may not really be appropriate to only treat them individually, right? Because it's a human being, and these may all coexist together. So
And
again,
as I often say, it's all the same brain.
yes.
And it's not like we have one neat and tidy part of our brain that where the PTSD sits, and another part of our brain where the TBI sits. It's all the same brain. And I am conscious of time, so as I add more. So if we can move along.
Yeah, absolutely. So you may again see some challenges in executive functioning. Again, those are those mental processes helping us to set and carry out goals. So it may be that somebody is not showing up for their follow-up visit, not necessarily because they don't care, but because they're having some challenges with their executive functioning and planning as well. Some potential cognitive difficulties as well that are listed here. And as Jackie mentioned before, you can have those short-term memory loss. I can't remember squat, or the disorganization. Again, my CPS worker's mad at me because I keep missing appointments, and I'm afraid I'm going to lose my kids. So these are real symptoms that they're feeling, and with real real outcomes that we're hoping to help with. Again, these are just some more examples of short-term and long-term outcomes that we may see from hypoxic or anoxic injuries. And functional recovery, it can be difficult to know how somebody is going to respond, even with mild, although most mild injuries do resolve. Some are very prolonged and may not resolve. And in particular, when you have repetitive after repetitive after repetitive mild brain injuries, they can be additive. So a team approach is really critical for this work. And again, many survivors may hesitate to seek care for IPV-related brain injury, whether it's from the cognitive symptoms that they're experiencing or safety concerns, possibly shame or stigma, fear of getting their partner in trouble or losing their children, or they may not even realize that they have a brain injury. Again, we all need to elevate and be suspicious that this may be occurring.
Yeah, and I think it's really important, that fear of losing custody of your children, because if you are, diagnosed with a brain injury, an abusive partner may use that against you in custody hearings. So we have to be very careful how this is documented.
Mhm. New article that came out recently in 2023 noted rates of potential TBI high overall when looking at IPV survivors as compared to individuals with no violence, and then those who are sexual assault survivors without strangulation or head trauma. They also saw lower scores on memory and executive functioning in those with IPV-related TBI as opposed to those who were sexually assaulted or had no violence groups. So again, more needs to happen for us to really understand and parse out how the different types of assault mechanisms can feed into this. And again, Dr. Toccolino and colleagues had this lovely article that came out on using the right tools and addressing the right issue, right? So looking at publicly available healthcare system in Canada, and they came up with 4 themes that are really relevant here. That identifying that brain injury and mental health as contributing to their experiences is critical, and that we need a strategy toolbox and flexible approaches for them. So there are some things that are out there right now that you can look into, and we have included the links, the hyperlinks for these. So in the journal Neuroscience and Biobehavioral Reviews, there was a recent article that looked at all of the current screening and assessment tools that can be used in identifying brain injury as related to intimate partner violence, as well as listing the advantages and the disadvantages of each. So again, there are screening tools that are out there. Here is one screening question, again, with the heads up, something short and quick that could then suggest that maybe more assessment could be indicated. The International Association of Forensic Nurses also has a wonderful non-fatal strangulation documentation toolkit, which will help you to capture all of these really relevant signs and symptoms, as well as to help guide the neurological assessments and find things such as petechiae and note things on body diagrams. The Training Institute on Strangulation Prevention also has their recommendations of the medical radiographic evaluation of acute adult non or near fatal strangulation. They have that both for adult as well as for pregnant women. That's a separate algorithm. And I know that they have been working on one for children, but this can also be very, very helpful in the clinical arena, particularly in the emergency or acute care areas. The UK has also provided some guidance here. And again, you're welcome to have these slides and take a look. The link is right here. And again, they guide in how to look into brain injury as a piece of the overall assessment. And the Australian Journal of General Practice also has guidelines too, and have noted that really we should be considering traumatic brain injury if there's any evidence of ongoing poor concentration or memory difficulties, any communication challenges, including this difficulty in following conversations, persistent altered mood, cognitive impairments, as well as personality or behavioral changes. Our Ohio friends have these wonderful resources as well, the CHATS tool and some additional head trauma information cards. And often individuals don't seek immediate medical care, so tools like this can be very helpful in other areas that aren't in the hospital or in the clinic, shelters, advocacy centers, et cetera. And then another article on a 4-country study of strangulation-related alterations in consciousness in women experiencing IPV, stresses and emphasizes again for us that we should be considering screening for brain injury that's caused by traumatic hits to the head if we've detected strangulation. So if we're detecting hits to the head, we should be asking about strangulation. And if we identify strangulation, we should be asking about hits to the head as well, because often these are combined in an assault. And then just Another notable from Ralston and colleagues, the forensic nursing groups are really doing some fantastic and exciting work here with some additional point of care testing for signs of brain injury during forensic examinations, again, with being on this a force plate, some near point of convergence testing, and some visual motor enhancement training. And with that, we want to thank you. We're so sorry that we're not there in virtual person to give this, but Jackie, any last words?
No, just to say thank you very much. And I think it's incredibly important that advocates consider these two forms of injury together. Whether the brain injury is from strangulation or from blows to the head, various insults to the brain that are the kinds that come from violent, aggressive tactics.
Thank you all so much, and we hope that you enjoy the rest of the conference.
Hi, everyone. So again, Doctors Campbell and Patch recorded the session, so we will forward them any questions that you've left in the chat. We are so grateful for you all for your time and being here for the last 16-ish hours. Again, we are going to have our breakout sessions, which we're going to start up as soon as we close this. Apologies. So if you want to learn more about ENIGMA, join the session. We'll be talking about research collaboration. There's an early career session. So if you're one of our early career trainees or researchers, please join. And then we'll have this session for 30 minutes and then get you to come over and hang out with the speakers. And the last session is our speakers. We will be all hanging out in a room with you. So come ask us any questions you have. And then we also ask that you provide feedback. We will email this out as well. But if you have time, we'd love it if you hover over this link and then go to the survey and give responses. We value your opinion immensely, and we use it to really plan these events. So whatever you tell us really helps us plan for next year. So please take a look at this. If you get it in email, fill it out. We'd be so grateful. And so with that, I applaud you all. I applaud our trainees and our speakers, and more than anything, I applaud the survivors for sharing all of their experiences today and yesterday. It will make a difference, and we are listening, and we believe you, and we are here for you. So thank you. It has been a pleasure, and I'm excited to see you all again next year. I speak for Catherine Schnedeker on that as well. We'll be back. We'll keep this going. We were impressed that so many people registered and so many people showed up, and we know everybody will watch the presentation. So again, thank you all so much. We will be in touch with the survey, and hopefully we'll see you in the breakout sessions and again next year.